Well, there's always a bit of a delay, so I'll just check whether it's actually started recording on.
Okay,
Yes,
that's
it has
great. Welcome everybody to this Outbreak Engagement Board. It's it's difficult. It's a time of some hope, isn't there, and optimism, but also there's going to be some very difficult statistics and messages from our public health presentation in terms of the course of the pandemic and the terrible losses that people in Reading have felt and their families or people they know, and obviously sickness is continuing on. So I think, yeah, a message of optimism, but very much non-complacency and a lot of hard work to be done. So thank you all for coming along. Nikki, do we have a second item on the agenda? Oh, hang on, shall I do?
You better do your thingy, and you need to read out that you're recording the meeting as well.
Announcements. So I'll read it out verbatim. I'd like to inform everyone present that this meeting will be recorded in Microsoft Teams and then will be uploaded and available for repeat viewing on the Council's website. Councillors, officers and partners attending will be asked to introduce themselves in the meeting. To help me manage the meeting, if any members of the board wish to speak during, please can you indicate your wish to speak in the chat section of the screen and then wait to be called, and this will avoid talking over each other. The sort of hand thing doesn't really allow me to know when people have asked and can easily miss. So if you can put that in the chat, if you can, that'd be great. When not speaking, all attendees should put their microphones on mute and switch off their cameras. And when called to speak, please switch on your camera, unmute your microphone and pause for about 3 seconds to allow for the slight time delay in connection. If you're addressing a meeting, it would be best if you can have your camera on so that people can see who's speaking. However, we are aware that we are at the mercy of individuals' broadband services, so it's possible that loss of connection may happen, or if your connection is poor, you may find that it improves if you turn your camera off, so we will understand if this is necessary. So like many people, I can't wait to actually able to meet in person for these kind of meetings, but we are where we are with this Zoom. So that was that announcement. Nikki, do we have any apologies?
Yes, Joe, I've had apologies from Maureen McCartney, Kate Reynolds, Paul Illman from the fire service, but Gail's here instead, Deborah Glassbrook, Jan Rothwell, Melissa Wise, and Vicky Rhodes is here instead of Kate Reynolds for that section.
Okay, great. Thank you very much. Okay, so we then move on to well, minutes of, and you jumped across, nearly jumped this agenda item, minutes of the meeting held on the 6th of November. I'm not planning to go through them page by page. Hopefully everyone has had a chance to look at them. So if there's any points of accuracy or anything people want to raise from those minutes, then now is the moment to indicate. If not, then we'll accept those and virtually sign them. I think Nikki apparently has got a massive pile of papers for me to sign eventually when we meet up. That'll be one of them to do. So thank you. I don't see anyone indicating, so we'll agree those. Then item 4 then is questions from members of the public. We've got a few questions today, so hopefully the first question is from Mr. Tony Cowling. I hope I pronounced Cowling. I hope I pronounced that correctly. Mr. Cowling, are you here in the meeting, connected and able to answer your question?
Sure, I haven't seen Tony.
Okay. Well, what I propose, I mean, obviously the answers are printed and will be published, but if Tony comes into the meeting before we finish the questions, we can come back to him and move to the 2 questions from Mr. Tom Lake first. Then, Tom, is Tom here?
Yeah, I've also put the questions and replies in the chat.
Okay, brilliant.
And I've published them on the web as well.
Okay, thank you for that, Nikki. That's great. Right, Mr. Lake.
Thank you very much.
Question number 4.
So question 4. At the time of writing, the King's College COVID symptom study estimates about 350 symptomatic cases of COVID-19 in Reading. Actually, today it's 264. Allowing for asymptomatic cases, we might have had, at the time of writing, 450, and perhaps it might be 300 and something today. In countries which have successfully controlled transmission, such as Australia, South Korea, Thailand, as many as 30 contacts per positive case are identified and isolated. At present, that would give us around 13,500 people isolating in Reading alone. Today, it might be 10,000. How many people could be effectively supported in Reading, and what would be the expected number of cases in Reading such that transmission could be effectively controlled?
Thank you, Mr. Lake, for your excellent, but also very difficult question to answer. Contact tracing is an important part of the control of a range of diseases, and this includes COVID-19. It is not possible to say with confidence what the exact number of cases is in Reading, and the King's College researchers acknowledged their figures are an estimate. Through our expansion of testing in Reading, both for those with symptoms and those without, we are picking up a greater number of our true cases now than at any stage of the pandemic so far. You are right to focus on contact tracing because we know that as prevalence of the virus falls and as lockdown is eased, the importance of contact tracing is all the greater to ensure that we isolate off the virus where it still persists. That is why in Reading we've developed a local contact tracing service to pick up where the national test and trace system does not reach our residents. This service ensures that we reach 90% of all cases who have tested positive and identifies their contacts that also need to isolate. This is well above the 80% target needed to ensure contact tracing is effective in reducing the spread of the virus. And finally, in terms of supporting people to isolate, the Council provides access to the isolation support payment for residents who face financial hardship if they isolate, and also access to the One Reading Community Hub for those who need various forms of social support during that time. It is still the case, though, that many people will face a stark choice about whether to lose essential earnings or follow isolation, and it is vitally important that the government listens to calls for more resources to support isolation, including more generous financial support to those who will lose out through loss of earnings that they cannot afford. And so in terms of the numbers, I think your estimates are probably quite reasonable. But yes, thank you. Mr. Lake, do you have a supplementary?
No, thank you. Thank you for your answer.
Let's go to, you've got another question? Question number 5?
Indeed. Shall I go on to the next question?
Yes, please.
Professor Gabriel Scally of the Independent SAGE panel, convened by former Chief Scientific Advisor Sir David King, has noted that the COVID control measures do not allow for testing the contacts of positively confirmed cases of COVID-19 for infection. Does Reading have the resources to initiate such testing, either with the gold standard PCR swab test or with rapid lateral flow tests?
Yeah, thank you, Mr. Lake. So the testing in Reading does utilise both the PCR test and lateral flow devices. With any test, it's important to understand that what the test can and cannot tell you. Whilst they both work in slightly different ways, they essentially tell you if you are currently infected with the virus to various degrees of accuracy, and therefore highly likely to be infectious to others. Neither test can tell you if you're incubating the virus after a recent exposure and are soon to become infected and contagious. Therefore, it's not possible at the moment to accurately deploy testing for contacts of cases to see if they have or haven't truly been exposed and are now incubating the virus, about to become infectious and need to isolate. Nationally, some trials are ongoing to see if testing technology can be developed to support this. Our approach in Reading is therefore to use the expanding testing resource in ways that are most effective based on what we know at the moment and how the test works. This includes the implementation of our key worker testing programme, which we'll outline in more detail later on in the agenda. Do you have a supplementary to that, Mr.
Well, I do. Your reply suggests that all of the contacts are potentially incubating the virus. But in fact, if contact tracing is thorough, one of them may be the source of the virus, the source of the infection. And this is when the source is detected, that's known as backward contact tracing. And backward contact tracing, then the source of the virus is very likely to give a positive indication with either of these tests. Backward contact tracing roughly doubles the effectiveness of contact tracing and isolation by doubling the number of transmissions intercepted. So the question is, would you reconsider the use of testing of contacts with the intention of perhaps introducing this backward contact tracing as an additional measure?
Yeah, thank you, Mr. Blake. It's not so much a matter of reconsidering. I think we're open to looking at where best practice and the evidence suggests that we can get most impact from the testing we have available. And I absolutely understand your point around expanding it out to contacts and what you say about backward tracing. And as further pilot testing and stuff happens around the country, we'll look at how we can deploy our resources. But at all times, it's about how you kind of maximise the impact of the resource we have available. But your point is well made, Mr. Lake, and we'll take it on board. Thank you.
Thank you.
Do we have Mr. Cowling back? If not, well, I'm back. He's not here. I don't think he is here. Is he, Nikki?
Seen him arrive, Chair. No.
Okay. In which case, yeah. If we does he get emailed the answers? We put them on the public record. We obviously to make sure.
I sent him the answers this morning. I sent him and Tom their answers ready for them to prepare supplementaries. I haven't heard back from him, and he's not there. So, yeah. Okay.
Thank you very much, Nikki. Okay. So the next item on the agenda is the update of the local COVID-19 situation. I think Mr. David Munday is going to lead us through this. David.
Great. Thank you, Chair. So my name is David Munday. I'm the public health consultant here in Reading. And the purpose of this agenda item is really just to update on the current COVID position in our borough. And I'll go through some of the numbers and the data that show us kind of where things are at, and then hand over to Vicky Rhodes, my colleague from Brighter Futures for Children, who will just go through the current impact and situation within education and within the children's services. So hopefully my other colleague Claire will be able to share her screen so that everyone can see the slides. And Nikki will advise, I'm sure, but we're happy to make these slides available after the meeting for people to have access to if that's useful.
Yep, I've got them all ready to upload.
Perfect. So Claire, I don't know whether it's in a kind of a presenter viewer mode. I don't know if you can make it fuller screen so that it can I think you've got the wrong screen showing. You've got the background screen rather than the slideshow screen showing, Claire. I think there's two PowerPoint windows.
Apologies. 2 seconds.
All right, it's easily done.
So whilst Claire is just fighting with the technology and bringing that bit together, I think the comments that Councillor Hoskins already made in regard to say that I think we're in a time of optimism, but we're also aware that there have been significant impacts since this board last met from the second wave of the pandemic, and you know, there's still a long way to go, I think, before we're truly through kind of all of the challenges that COVID has posed us. So Claire, if you move on to the next slide for me, please. Thank you. So this is just to show you the headline figures for Reading, kind of first of all. So I've highlighted there with the red arrows, the Reading row. And in green, you can see the figure 3.2. So that is the percentage of people who are going for tests in Reading that come back with a positive result that shows they have contracted COVID-19. And that's of people that go for testing because they've developed some form of symptoms which may be COVID-19. And that number is coming down really quite quickly, I'm pleased to say. And to give you kind of context, probably in early mid-January, that was around 20%. So that has dropped significantly over the last 4 to 6 weeks. You can then see the next column along gives us the overall case rate in Reading, and we measure this per 100,000 of population, and this is in a week. So what this tells us is that for every 100,000 people in Reading, 85 of them within a week period are testing positive for COVID-19. And again, for context, when we came out of national lockdown 2, which was on the 2nd of December, our rate was around 150 per 100,000. So by the time we actually move out of this lockdown with those first steps on the 9th of March, and I'll mention a couple of things about that release shortly, our rate is projected to be kind of under half of what it was back in December when we came out of lockdown. So hopefully in a far stronger position for us to kind of maintain a release from lockdown and not to see additional kind of spikes and waves of infection. And then if you move along to the next column, you see 73.7, and that just shows you what our case rate is specifically in over 60s. And the reason that we monitor that closely is we know that infection rates within that age group are the ones which will most impact on acute hospital services, because they're the group that are most likely to become seriously unwell with COVID-19. You can also see the numbers for other boroughs there, but I'll show you some other data just that probably more easily compares, kind of puts the Reading numbers in a geographical comparator shortly. And just to say before we move on, these data are all available on the link that's at the top of that slide. So this information is readily available in an ongoing way for people to view as they wish. So next slide, please, Claire. So we segment data in Reading in a few different ways, just to try and be as forensic as possible with understanding how the virus is behaving locally. At a previous Outbreak Engagement Board, I presented information, and my colleague Yasmin did, regarding how it's affecting different ethnic groups. What I'm showing you here is how it affects different age groups. So across the very top row is that case rate. So again, in a week per 100,000, what's happening for all ages in Reading, and it's showing you the numbers spanning back from the 26th of January through to the 20th of February, so an almost 4-week period. And you can see that we've come down from 442 all the way down to 85. But then the subsequent rows break that down by the different age bands that you can see labelled on the left-hand side. And you can see that the good news, I think, for Reading is that every age band has seen a significant reduction in those case rates, and there isn't a single age group which has kind of been left behind in terms of not seeing that reduction. And as Vicky will come on to talk about shortly about the school reopening, we can see that, particularly when you look at primary age, the rates are really very low now in that age group. And we'll talk about within secondaries some of the things to do with lateral flow testing that we're implementing to ensure it's safe then within secondary schools also. So I think that's hopefully a helpful segmentation of some of the data. If you go to the next slide, please. So I promised a little bit of comparison just to put the Reading story in context with the other kind of parts of Berkshire that we work very closely with on the pandemic response. And you can see that these data just show each of the 6 local authorities in Berkshire, and the blue line on each of those 6 graphs is the trend, the case rate for that specific borough, and then the grey and the orange, which if you look closely you'll see is identical in each of the 6, shows you the southeast and the national picture. And what you can see is that the spike of this second main wave occurred kind of early in January, if you can just about make out the dates on that kind of bottom axis, and it's a little hard to see. And that was kind of a common picture in terms of where the spike occurred across Berkshire and across the country. It took a few days, maybe a week longer, for Reading to start to see that consistent decline that was seen elsewhere and that was seen nationally. But what you can see now is that the lines have all converged, and we've had the same, we've reduced down to the same rates as has been seen elsewhere. So that's encouraging to see. Next slide, please. And then just to show you that rate of decline in the most recent week, what you can see on this just on this map that's color coded is that Reading has seen actually a very rapid drop. So that rate of change is on the right, and you can see the fact that that things have reduced down quickly, and then what the overall kind of rate for us is, as I pointed out before, but then below 100 per per 100,000. And then if we move on to the next slide, so to kind of go back a little bit, the peak that we saw in early January was almost entirely to do with this Kent variant that became the predominant circulating strain of COVID-19 over the course of December. And like other parts of the southeast and then across the whole country, this variant has been the biggest driver of the second wave of infections that we've seen. There's a few points on this slide. I'm not going to go through all of it, but just to say we know that this variant is more transmissible than the original variant that was the predominant strain circulating, and that's why it's become the dominant strain within the UK. But probably a couple of really important points to note about it. Firstly, viruses mutate all of the time. That's how they behave. We know that a lot, particularly from the flu virus. So it's in a way it's a kind of to be expected when we see viruses mutate. It's important to note that this dominant Kent variant is still detectable on the tests that we have available, and the vaccines that we have available are still effective against it as well. So although yes, it's a mutation and it's a change, it's not one that leaves us without tools in the toolbox to be able to fight the virus. And just to show you some of that in numbers, if you move on to the next slide, please, Claire, this just shows you in the orange the original kind of main strain of the virus that was circulating, and this is data for Reading specifically, and the bar charts start in early December, and by then we had about a third of cases had become the blue, which is the Kent variant. But by the time we move up into mid-January, almost all cases are then the blue, the Kent variant, and very few the original strain. And as numbers have fallen, we can see that kind of trend of the split, if anything, becomes more dominated towards the variant, and that's because it has a selective competition advantage because it's more transmissible. And clearly there's more work that is going on, or ongoing work, should I say, regarding monitoring of other variants that we heard about in the media, but there is no other types that have become as prevalent in Reading or in the country than the Kent one that we've just discussed. So if you go on to the next slide, please, Claire. We've obviously continued to track closely the mortality from COVID in Reading, and this is clearly quite a sober slide because the blue bars in this graph show us the deaths that have occurred in Reading where COVID-19 is on the death certificate. And we can see, and this starts from the first week in March last year, so we have virtually a year's worth of data now, and we can see the first spike that happened in April of last year, and then we can see a flatter but certainly a spike in deaths that have occurred this winter in Reading. I think we're now in a position where we can see that we have moved through the spike in deaths. We are still seeing some COVID-related death, and we're not aren't going to pretend otherwise. But it is reducing and moving in the right direction. And as our case rate continues to fall further, and I've shown you the numbers in terms of the most frail and elderly and how the rates have fallen significantly in that group, we expect to see that reduce further. If we move on to the next slide, then, Claire. So the last couple of things that I wanted to say were really then just because a lot of that's been either the backward look or the current position we're at today. The forward look then is based on the plans to release Reading and the country, obviously, from lockdown going forward, which the government announced earlier this week. And I've just got two slides here to show you kind of a summary of what that means. And I'm sure people have seen a lot of media coverage around this. So I'm not going to go into this in every detail. But we know on the 8th of March that that schools and colleges will be fully opening for children and residents in the borough. And we know also that by the 29th of March, the rule of 6, or the 2 households together, if they happen to be more than 6 in total, can meet in an outdoor setting. And I'm sure people are looking forward to be able to mix and socialise more. And the reason, of course, that that's an outdoor allowance is because of the reduced transmission risk in an outdoor setting. When we move on to step 2, then, which would be on the 12th of April or later, if there's a bit of an impact from the 29th of March and the 8th of March, and the government feel that that needs to be delayed. But from the 12th of April, then we see, some of those businesses and key services starting to reopen. But it does remain, in terms of social contact, that rule of 6, or 2 households outdoors, and not having more mixing indoors, kind of at that point. And then if we move on to the next slide, Claire, the 3rd step then, which would be mid-May, but as we say, could be pushed back, does allow the social contact to move indoors. And then we can see that hospitality and other business settings are able to kind of open up in that phase of things, as well as then the return of more events. And I haven't looked at the football fixtures and whether that means anyone will get back to the Medeski Stadium or not before the end of the season. Maybe playoff campaign dependent for football fans on the board. And then finally, then the 21st of June is really where the hope is to be able to move to that more fuller relaxation of a lot of the rules and the restrictions that we've been living with now for a year. Although I think we have to be realistic that there may be some restrictions, even if this lockdown release goes according to all of these dates, and there aren't any delays. There may still be some requirement to be living and working in COVID secure ways despite the relaxation, but that is something that we will obviously know more about nearer to the time. So I think that's everything I wanted to run through. So I hope that is helpful, Chair. And Claire, if you move to the next slide, I think it moves. Yes, we'll go straight on to Vicky Rhodes, my colleague from Brighter Futures of Children. So I will stop there. But once Vicky's concluded, then more than happy to take any questions or comments.
Thank you, David. So as people know, I'm here attending on behalf of Kate Reynolds, Director of Education today, who's chosen a fantastic day with the sun out to take a mini breather. So if we could go to the next slide, this is a little bit of looking back. Up until this week, our big focus between the Christmas school holidays and last week has been increasing the number of our vulnerable children attending school. We've had a really concerted effort between social workers, early years teams and our education welfare officers to work alongside schools and our early years settings to really help reduce parental anxiety, which seemed to be the main factor in impacting those children that were coming on site. And with a real concerted and aligned effort, we did manage to nudge our on-site attendance up to 80.5% this week, with a much improved 48% of children with a social worker attending their on-site lessons. So that's certainly been the focus over recent weeks, and I think that table is just to show you how many of our vulnerable children, which as you will know had a much expanded definition recently, so it was a bigger cohort of children that we were seeking to support. But as of this week, as everybody knows, if we can go to the next slide, please, Claire. So we received our first of many DfE guidance updates on Wednesday, which confirmed that all schools, colleges and further education settings will be allowing for full attendance from the 8th of March. Wraparound childcare, including childminders, will also open for eligible children. And importantly, school attendance will become mandatory for all pupils, with secondary schools and colleges able to phase their return over the week of the 8th of March to allow students to be offered testing on their return. The usual rules and duties around attendance resume from the 8th, and all schools will now be communicating their expectations about regular attendance to both pupils and parents. Schools will be identifying those pupils that may be at risk of disengagement and developing plans to re-engage them in their on-site education. And our Education Welfare Service will be supporting schools with this, particularly where parental confidence is impacting on those children coming back full time. All early year settings will be fully open to all children from the 8th also. In further education settings, the DfE expect that every 16 to 19-year-old student, or up to 25-year-old for a student with an education, health and care plan, will undertake the majority of their planned hours on site. Rapid testing remains a key part of the plan to suppress the virus in education and childcare settings. This means that asymptomatic people who might otherwise continue to attend educational settings are identified and self-isolate. And I know that David's going to talk in much more detail later on testing, but this is going to be key to how we keep our schools and nurseries COVID secure as they either reopen or continue as they have been. So the twice weekly asymptomatic testing is already available for the majority of education settings, including support staff such as teaching assistants and those supporting wraparound childcare. Secondary schools and colleges have also now been able to offer testing on return for their students, and the DfE have asked for this to be in place for all students from the week of 8th of March as they return. Over and above testing for pupils in year 7 and above, it's been recommended that face coverings should be worn by staff and pupils where social distancing cannot easily be maintained, such as in corridors or communal areas. And for a limited period, DfE are recommending face coverings in classrooms or other teaching spaces, unless wearing that face covering would impact on ability to take part, such as PE or for those children who are exempt. In primary schools and early years settings, face coverings will only be worn by staff and adult visitors where social distancing is not possible. Children in primary schools will not be required to wear a face covering. And then further guidance that has come through since the middle of the week, the DfE have confirmed that GCSEs and A-level students will receive their grades awarded and determined by teachers, with pupils only being assessed on what they have been taught. We've got the opportunity to take part in a further webinar in March, which will focus on transitioning pupils and students from testing on-site to testing at home. We still await further details on catch-up funding for schools from government and what potential additional support is going to be available for children's mental health. In terms of the additional support that we've been able to mobilise to vulnerable children through this period, the Winter Support Grant has continued and will do until the end of March. And in February half term, food vouchers were provided for all children eligible for free school meals. And as of Monday, 75% of those had been taken up. We've been liaising with our colleagues in the council, and we know that this week we've launched the fuel support element of this programme, which will be providing an additional £49 per vulnerable household towards their utilities bills. And then looking ahead, on behalf of the council, Brighter Futures for Children are coordinating the Holiday Activity Fund. This has been a scheme that's been piloted in other areas and is now rolled out across the country to provide free school holiday activities until December, with a focus on healthy eating. This will also be for children eligible for free school meals, and our Easter scheme will be a blend of virtual and direct support, with a focus on direct group and activities through the summer holidays. And I guess more generally around the impact on children's services, we have our annual conversation with Ofsted next Wednesday. This will be to review the impact that COVID has had across children's services and identify those priority areas of focus over the next year. That is likely to include the increase in child protection and complex cases that we are seeing coming through our front door. So whilst I might not be able to answer some of the more technical queries regarding schools, I'm happy to either take questions or feedback any queries to Kate. Thank you.
Lovely, thank you. Thank you very much for that. So there's an echo there. I think Vicky's put her mic on. Okay, so I thought that was a great presentation. I thought the interesting elements that jumped out to me were around the timetable, the dates that have been outlined by the Prime Minister, even though he promised data and not dates would drive things, are very much not before rather than things will happen on. And I think that's something that we perhaps need to think about messaging. And I know we've got communications coming up next. So maybe it's anecdotal. I noticed that people seem to be, how can I say, relaxing a little bit, socialising outdoors immediately on from the announcements from the government. So I think it's going back to that alert and avoiding complacency. I think that's something we need to consider. Also within that, I think it's worth pointing out that larger events is one of those things on the timetable. And what's become apparent from comments on social media and people contacting the council is that some people are under review that the council has approved the Reading Festival taking place this summer. That's not the case. The council nor anyone else has agreed anything. But certainly the announcement is the intention of the Reading Festival to happen. That's going to be a major item for our licensing department and various other national bodies to consider as the time comes. But nothing has been agreed by the council, unless I'm contradicted by officers. That's absolutely the case. Right. OK. Any questions? Any points anybody wishes to make? I haven't seen anybody indicate. I've got Mandeep's put her hand up, but I haven't seen anyone else indicate in the chat. Mandeep, if you'd like to ask a question, introduce yourself, as you do say. Thank you.
Sure, I'm Mandeep. I'm the Chief Exec of Healthwatch Reading. My question is for Vicky. I see that the schools must conduct lateral flow testing on pupils 3 times a week, and I just wondered what support and guidance are you offering schools? It seems like a huge undertaking, so I'd just like to understand a little bit more about that and what sort of guidance and support you're offering schools in order to do this.
Thank you, Mandeep. Vicky.
Thank you. David might have to support me. So I know that David in particular has been offering a huge amount of support to our schools and regularly attending head teachers briefing, which we hold on a weekly basis. And I think this is a piece of work that the schools have been gearing up for since January, really. But I don't know, David, if you can add to some of the technicals.
Yeah, and I think it's a good point, because it's not that schools had lots of space or spare time kind of that was just in surplus to which can now just simply be deployed on undertaking testing. So the approach that was taken initially when testing in secondary schools was announced was that we supported specifically one of the secondary schools in Reading. It was Hugh Farringdon School to be the pilot site to kind of test the concept, if anything, and see how it worked, what went well, what didn't go well, etc., and then roll that learning out to other schools in the town. And that's certainly been done, and I think was an effective way of trying to embed something which was announced and was announced nationally and expected nationally to be implemented pretty quickly. So I think that was the kind of pragmatic local approach to doing it. In terms of how the testing in schools will happen going forward, we're allowing schools to do, so they're being asked to do 3 tests for secondary pupils, and then convert to home testing. But what we're doing is allowing schools to do a staggering of those 3 tests. So where it is operationally better for schools to start the first of those 3 tests before the 8th of March, they're able to do so. And then we're able to offer flexibility in terms of when tests 2 and 3 are as well. And then it's actually about supporting then families at home, because it's then a home testing process that will be kind of adhered to for secondary school pupils. So that then changes the dynamic a bit, and that's where the kind of the instructional videos, the different leaflets, the fact that pupils have done the test with trained supervision for 3 times kind of hopefully helps build that competence. And it's important that that competence is built, because we know the test is most accurate when undertaken in the exact ways that it's designed to be done. And the trials have shown if you have a trained health professional doing the test or someone untrained with no explanation, it's far more accurate in the trained environment. So I think we need to make sure we get that bit right. So I hope that helps provide a bit more of an insight into that, Mandeep.
Yes, thank you, David. That's really helpful, and I would encourage all parents and students to kind of tell us how things are going along the way, because it seems like you're testing and amending as things go. So
yes, I think that's a fair point.
Thank you. And I've got 2 secondary school age daughters, David. So I'll let you know how it's going in Reading schools.
I'll be very interested to hear.
I'll keep you updated on a frequent basis. Okay, is there any other questions? Anything? I haven't seen anyone else indicate. I've got a final question that occurred to me as through the presentation. It doesn't necessarily have to be answered now. And that was around the take up of the free school meal vouchers. Obviously, this is becoming will become less of an issue as pupils return, but I think there might be lessons learned. Now, 75% to me seems quite low, in the sense that maybe 25% of people who need this support not getting it. So I wondered whether how that related to other areas, and whether there's any sort of learning about why people weren't necessarily taking it up, and if we're in this situation again, that we can learn from that. As I say, I don't know if we have an answer to that, or maybe something to come back to, but Vicky.
I can respond to that, Chair. So the benchmark was the take up last summer, when the first voucher system was introduced, was not quite 60%. So when we went into the Christmas phase, actually 75% was much higher than we'd anticipated, and we ended up going slightly higher than that at Christmas. I think the learning from February, that actually that was within 1 day of the half-term holidays finishing, and we were already at 75%. So I think we'd achieved a phenomenal amount of learning. And what made it much easier in February was the schools primarily delivered the scheme. So we all had an Edenred account. By that time, it meant schools could just go in, upload their children and families' details, and then we just paid for that through the Winter Support Grant. So it's actually been a higher take up than we had anticipated, and one that we think will exceed 80%. We've always ensured through bulletins to head teachers that had anybody been struggling to access their voucher, they could contact either ourselves or the One Reading Hub for additional backup. So we've been quite pleased actually with that level of take up.
Thank you, Vicky. And my question was very much one of ignorance about how that might work in practice, but it sounds like it's an area that you've given a real emphasis on ensuring take up. So thank you for that. Anybody else? I don't see anybody else indicating, in which case thank David and Vicky for that presentation. I think that's really useful to us all. So the next agenda item is communications update. Do we have, is it Nikki Barton?
We've got me, Chair. It's Amanda McDonnell.
Hello, Amanda.
Hello.
Thank you. Over to you.
Okay, so I will take us through our COVID pandemic communications update. So our strategy, next slide please, Claire, thank you. is three-pronged. So to amplify our national messages, share those from the NHS, Public Health England and the government, respond to emerging issues and communicate messages of local significance. Most important is our locally targeted communications. You know, people are seeing national messages on the news, and it's really up to us to tackle the local issues, the barriers, and any concerns. Next slide, please, Claire. Thank you. So we've based our local activity on insight and the intelligence that we get from research, feedback, and engagement with local people and also groups. And in terms of insight, vaccine hesitancy has been widely reported. Failure to isolate, we've also already mentioned, and not just failure to isolate, but understanding what self-isolation is and also the self-isolation support payments that are available. It's emerging about young people's concerns and their mental health. And there's also something coming out around, you know, I'm following the rules that others aren't, so why shouldn't I? So some of our messaging has got a little bit harder, and it's been well received. And then there are groups and or locations where, you know, it's more at risk. So for example, playgrounds, we've had some messaging there that I'll show you. Next slide, please. Thank you. So on the right, we've got Nisha, who recorded a vaccine hesitancy video for us, and we've produced a few videos in a number of different languages, and I know David will talk about that a bit more later. And then at the top, we've got Tony, who shared his self-isolation case study or story, and we've had a number of residents who shared their stories, whether it be their COVID experience, having had it, or their family's experience, or their vaccine experience, or their self-isolation experience. And then at the bottom there, we've got our playground messaging that we've had up in playgrounds, you know, at the very moment where we need to remind parents that when they get home, everyone needs to wash their hands to sort of help prevent the transmission of the virus. Next slide, please, Claire. Thank you. And then here's some examples of our paid for digital activity. Now, this activity reaches people that aren't following our channels, for example, that aren't following our Facebook page or our Twitter. And these messages have been along the self-isolation, it's the law, stay at home, vaccine messages, and then also that support from the One Reading Community Hub that is out there. And these link through to surveys. And through those surveys, we can test and learn what people's understanding are. And then we're also reaching people through a number of other channels. So our weekly or bi-weekly email that goes out to over 100,000 residents, through all of our social media channels, digital screens, and also targeted Q&As that we've done with the care sector and also community leaders. Next slide, please, Claire. Thank you. So we're learning all the time, and certainly, you know, what does work is locally produced, authentic, quite raw content using real people, and our real residents really help to amplify those messages. So they're helping, you know, they see themselves on Facebook and they're sharing on their Facebook pages. So it has this kind of twofold effect. And again, it's coming from a trusted source. It's coming from someone they know. Also using staff and local spokespeople. So Councillor Khan helped us with his vaccine experience video in both Urdu and English, and our playground officer as well. We produced a video with him talking about, you know, how to keep children and parents safe using our playgrounds during the pandemic. And this, you know, this really helps to personify and personalise our messaging. As I mentioned earlier, we're having a good response to some harder messaging, and also certainly in terms of our public spaces, we've had to produce some banners reiterating that our sports courts are closed and to prevent people from accessing those. Okay, next slide, Claire. Thank you. So we really welcome your feedback. As I say, you know, using real residents in our comms really helps in terms of engagement. So if anyone out there would like to sort of take part or share their experience, we'd love to hear from you. And yeah, happy to take any questions.
Great, thank you, Amanda. Anybody with any questions or even views or points on to raise? I haven't seen anybody indicating. what people think about whether they want to or not. Thank you very much for that presentation. I absolutely agree that the local and the more real agenda messaging is absolutely right. And I think this is not for to answer now. I think we just need to reflect upon how the government messaging is going to land with local people. Certainly, sort of the experience of the last sort of easing of lockdown was that people were running ahead of announcements. Perhaps people were thinking they're virtually there when actually it was a few weeks off. And I think we need to think about how we react to that in terms of people of Reading. I've got Andy Czerski indicating. Andy.
Yes, thank you, Chair. Hope you can hear me all right. Just a quick question, Amanda. Great work. And just thinking, coming out of lockdown is going to be a challenge to understand what we are or aren't allowed to do. So have you got a plan for getting what are the rules coming out of lockdown through the various steps? Because there's quite a few and they can be quite confusing. Thank you.
Yes, definitely. And it's something that we're working on. And also, I guess, with the caveat that we've got these dates, but those dates could change as well. So we're very mindful of all of that. Yeah, in terms of experience, thinking back to before Christmas, I think within about a 2-week period, we went from tier 2 to lockdown. So we sort of have that experience of those sort of complicated messages in quite a short period of time. And we're very much learning all the time. And, just to reiterate that local residents helping with that messaging really helps in terms of engagement.
Absolutely, thank you, Amanda. Anybody else? So you've got the request there. If anything does occur to you, any views, any feedback, any suggestions, and you know to contact Amanda and the team. There's the email address. That would be great. So thank you, Amanda, for that presentation. So the next item is a standing item, and it's and it has to be on here. The recent outbreaks, lessons learned. We do have Meriden Peachy. Are you going to give an update on lessons learned from recent outbreaks?
It's James Crosby doing this one.
Oh, sorry. Sorry, I may have looked at a slightly older version. James, would you like to introduce yourself and go on?
Yeah, of course. Good afternoon. I'll just close my curtain a little bit because it's very bright this afternoon, which is beautiful to see the sunshine. My name is James Crosby. I look after our environmental health service at Reading, and as part of their duties, they're responsible for looking into outbreaks. And this is just a quick case study, really, to show the type of activity we do once we find that an outbreak's occurred. So, Claire, if you wouldn't mind starting, thank you. So this is quite an interesting one in the sense that usually in normal times, the types of outbreaks we deal with, might be things like food poisoning outbreaks, or there are occasionally, those sorts of things like TB, pretty rare, but we do deal with those sorts of things. But in this instance, we had a report of an outbreak actually over the border in West Berkshire, where there'd been some reports of a school cluster that had positive cases. Working with colleagues over in West Berkshire, we identified that this outbreak had been caused by a professional and academy sports team that had been moving across between the border, and effectively unknowingly, unwittingly transmitting the virus between themselves and the kids that they were teaching. The academy had been playing regularly at a secondary school, and that school had already had an outbreak and had already closed, which was great news to hear that they'd already taken that proactive activity. But what we didn't know at the time when we had the report was whether there was any formal link between the school and the actual club. Claire, if you wouldn't mind the next slide. So what we do, and we do under normal circumstances and during COVID, is we'll always try and make contact with the individuals that are responsible for either, in this case, the club, or it was out of hours, so there wasn't a contact at the school at the time. And we were able to establish off the club what they'd done since they found out that they had that number of positive cases. And they've been very proactive in what they've done. So they've contacted all the players and the parents, and they've isolated all of those players, including the contacts of those players as well. And they've done that in advance of us actually being notified of the outbreak. The club had proactively closed all its extended branches, so those branches that were outside of Reading, and to ensure that there was preventing any further cases. A remote inspection of the measures have been carried out by our team. So effectively, we would look at the government guidance to see what the guidance for sports clubs were, and for those particular settings, those school settings, and we would go through and make sure that those measures were being adhered to, asking for risk assessments and the COVID secure checklists that have been carried out by the club, just to make sure that they still had all the right processes in place. Our view at the time was that the club had been operating within the guidance, but clearly, you've got to look at the controls that they perhaps weren't aware of in terms of moving across the borders and going into different settings. On that occasion, there wasn't any further action required. But Claire, if we can go to the next slide, please. Just to kind of outline some of the challenges that we have, really. So a lot of our reports will come in through Public Health England, so we will get a notification of an outbreak. But a lot of the outbreaks in Reading have been very small, so one or two, two or more cases, and generally in households, so not huge numbers of business outbreaks. And as you can imagine, in the lockdown, that's less likely to happen. But what we're not getting really is companies coming direct to the local authority and saying, "We've got an outbreak. Can you assist us with it? Is there anything that we haven't done right? Is there anything that we could be doing differently to prevent this spreading either to our staff or to our customers?" And we've been doing quite a bit of work in trying to encourage companies to come forward on that. There's varying levels of information that have been provided to us. So sometimes, we're getting anonymous complaints in. We're getting information from PHE or others telling us that they've had conversations with the business, but we don't always get the full information to tell us exactly what's been discussed and exactly what's been dealt with. There are some premises with outbreaks that aren't known to us. So if you can imagine, I'm trying to think, we sort of identified at the start of COVID, we've got something like 7,000 businesses which we would have an interaction with. But a lot of those businesses might be those that are enforced by the Health and Safety Executive, for example. And we wouldn't necessarily have their contact details. And therefore, when we're now having those businesses referred to us as being a company that we now need to speak to, we don't necessarily have all their contact details. So that it's an extra layer of difficulty for us in terms of trying to engage with those businesses. As mentioned in here, the health and safety enforcement role is shared by multiple agencies. So, Health and Safety Executive is responsible, for example, for construction sites, and that's where we've seen quite a lot of transmission. But we would be responsible for food businesses. Public Health have been quite successful in contacting head offices. During early on in the pandemic, we were getting some referrals to the council about outbreaks that we thought had occurred in our area, but actually they'd been reported to the head office in Reading, and they actually happened outside the area. But we were able to sort of identify that quite quickly and make sure that that was being dealt with correctly, and the referrals were being made in the right way to the right authorities. And I think the last point here is really about that sort of, we do get a lot of anonymous complaints about businesses. So that's perhaps where people are a bit concerned that if they report the information and they're an employee, that they're going to be disciplined in some way, that they're going to be laid off. And so there are a lot of anonymous complaints that do come in. All of them are investigated, but it's quite difficult to then verify the information. There's nobody to go back to and discuss what we've found when we've spoken to the businesses versus what the person who's complained felt and how they were treated when they were in that business. So they're just a bit of an overview of the kind of things that we deal with. But if there are any questions, I'm happy to take those.
Thank you, James. Right, any questions, any points? Anybody wishes to raise? I've got Dr. Prem Sharma.
I was just interested to know how you have this remote inspection of COVID control. How you do that?
Yeah, sure. So the Health and Safety Executive done quite a lot for this as well. So essentially what we're doing is we're going through the guidance that the government issued and asking questions about sections of the guidance. So how is somebody actually complying with that element of the guidance? And we're asking them to describe how they do it. If we've got, so with the HSE, for example, the way that they work it is that if they get some questions where they're not getting the information that they think they should be getting or the answers that they should be getting, they're flagging that up with us, and then we go out and we do a physical inspection. So we're doing the virtual inspection as more of a kind of triage to make sure that we focus our efforts on those that we think are most likely to be non-compliant.
Thank you very much.
Thank you. Anybody else? In which case, James, thank you very much for your presentation. I think it's worth saying that there's been an enormous amount of work done from a team of workers across the council, particularly around the various enforcement areas that are already pretty strained and stretched even before the pandemic. So I think personally, I'd like to express my thanks to the teams and the hard work over what must have been a really, really tough year. And in fact, reflect upon, yet again, an area where if government hadn't hollowed out a lot of the funding for local government, the response across the country could have been even stronger in terms of dealing with this pandemic. But thank you, Mr. Crosby, for your presentation. It's anyone else indicating. OK, so the next item is the COVID-19 vaccinations. We've got a presentation on what information we have. Is that Mr. Monday again?
Yep. Thank you, Chair. Absolutely. So we'll go through what the current situation is in terms of the vaccination programme locally, and I'm happy to take any questions or kind of comments at the end, of course. So move on to the next slide, please, Claire. So the I can see a blank screen. I don't know if there's a further click to be done.
It's not. I don't know why it's not showing.
OK, that's fine. Don't worry. We could move to the next one. Oh, there we go. Fine. So before we dive into the kind of details of how rollout's working kind of locally, it's sometimes useful just to take a step back and just kind of remember how vaccinations work and what we're aiming to do with them. So on the left here, you've got just a very simple kind of preschool exercise where you match the name of a shape to how it appears on a page, and clearly just draw a line between one and the other. And all that really your body is doing when it fights off infections is seeing a shape that comes into the body, so the germ, the infection, what we sometimes call the antigen, and then matching it to the antibodies that it has that recognize that shape and are designed to kill it off. If we invented a brand new shape that had a couple of straight lines, a bit of a curved line, a line going off in an odd way, and wasn't really a shape we're familiar with, that's really we wouldn't be able to match it to a definition of a shape. We wouldn't be able to match it to a description that we know, and that's kind of what happens to your body with something like this COVID-19 infection. Essentially, it comes in and the shape of the infection is not previously known to the body, and it doesn't have any antibodies that can identify it and kill it off. So on the right hand side then is the kind of, if you like, scientific picture of what COVID-19 looks like, and the orangey kind of spiky bits are called the spike protein. And that's the shape, that's how it looks to the body when it comes in. So all we're doing with vaccination is showing the body a brand new shape that it's not previously seen, so that it can create antibodies against that specific shape, so that in the future, should the body be exposed to that shape, it's got the antibodies there in waiting, ready to kill it off. So that's what we're doing now. We show that shape to the body in slightly different ways with different vaccines, and the Pfizer vaccine does that in a slightly different way to the Oxford AstraZeneca vaccine. But that's the basic science of what we're trying to do. In terms then of the actual rollout, if we move on to the next slide, Claire, just to talk through then how this has been working in Reading in terms of getting vaccination to people, and clearly, and on a subsequent slide, I'll talk about how this has been prioritised. But just to give the overall kind of structure of how we've been working. So our GPs in Reading have been working tirelessly, first of all, to ensure that care home residents are all vaccinated, because we know all too well about their vulnerabilities to COVID, and how outbreaks can occur in a care home setting, and also offering to staff in those care homes. Secondly, then, and again, it's been our GP colleagues that have been hard at work via the 5 primary care network sites in Reading, and that is where GP surgeries club together, because you've got the right economy of scale to be able to efficiently deliver kind of a mass vaccination programme. So you can see the 5 sites there, and that's how the majority of people in Reading have been vaccinated, and they've been invited up to that surgery at the appropriate time when their group has been kind of given the green light to be vaccinated to have that done. Thirdly, then, we have had a hospital hub locally, so one at the Woking Community Hospital and then also at the Royal Berks Hospital, who have been offering vaccination to the health and social care workforce, who clearly need to be vaccinated, because they're being exposed to the virus in the nature of their job, and also because they could otherwise inadvertently pass COVID on to vulnerable patients or people that they care for. Fourthly, we've then had more recently a pharmacy, so the Triangle Pharmacy in Tilehurst has opened up. So the same groups that the primary care networks would be vaccinating could instead go to a pharmacy site if that's more convenient. And that's exactly how we run the flu campaign each year, where there's an offer from primary care and there's an offer from pharmacy. And then finally, this week, as I'm sure people have seen in the press, the mass vaccination site at the Medeski Stadium went live. So at full capacity, that would be vaccinating about 10,000 people a week. Although at this point, it started obviously at a smaller number than that and moving up. So it's doing, I think it's around 500 a day. So but doing a 7-day-a-week operation. So but it will ramp up to the 10,000 capacity. So that's the kind of where we've been running vaccination. On the next slide, what I've highlighted for you is just the different priority groups that have been set nationally by the Joint Committee for Vaccine and Immunisation. And you can see that in green, we've got 4 groups. And the reason I put them in green is simply because everyone in Reading who is in that group, any of those 4 groups, have now been offered vaccination against COVID-19. In yellow, then, are the groups that we're currently vaccinating, and people today will be going forward from both the 65 to 69-year-old cohort, and then also those younger than that, but who have underlying health conditions or risk factors for complications from COVID. So that's happening kind of as we speak, and that work will progress through over the coming weeks, and then move on to those final 3 groups that are marked in red, simply just because we've not started with that then slightly younger cohort yet. And we are, I'd say, a bit ahead of the curve in terms of rollout nationally. So we've been managing to push the vaccine out quickly in Reading, which is great. And the reason that these groups exist in this order is because it's essentially been ordered in the way that the risks of serious illness and mortality from the virus are are most likely to fall. So we know the most elderly and frail are the most at risk, and then we've kind of moved down the risk groups from there. And then it was announced this morning by the government that that those aged under the age of 50 will be vaccinated in 3 age band priority orders. So once everyone to the age of 50 has been offered, it will then go to those down to the age of 40. It would then go to those down to the age of 30, and then it would go down to those aged from kind of 18 up. So the future rollout, once we finish with what's on that slide, will again continue on that kind of age stratification. In terms of then actual numbers, on the next slide, what I have tried to put in, and apologies it's slightly small, but hopefully you can see it, is just what that means in terms of raw numbers in Reading. So you can see that in total we have around 30,000 people that have been vaccinated in Reading, who are within the cohorts that have been offered vaccination so far, and that number is increasing every day. What we haven't yet got is the verified data, which gives us that as a proportion. And because what we really want to understand as well as possible is of everyone who is over 80, for example, has every single over 80-year-old been vaccinated, or what proportion have? And the unpublished or kind of verified data looks like those first age groups are kind of in the 90% uptake levels, which is extraordinarily high for a vaccination campaign, and is really good news that people in Reading have been engaging. So more data will flow in the coming weeks that just gives us that more detailed breakdown, and also breakdown by kind of sub-borough area, so we can see if there's differences in different parts of town. And I'll come on to what we've done in terms of engaging some of the groups that we know may uptake the vaccine least quickly. I'll come on to that shortly. So that is hopefully helpful in terms of numbers. The next slide just shows you then some of the campaign work that we've been doing just to promote the vaccine against the virus, and how we've been going about that. So clearly, and as Amanda's already spoken of, we've been trying to generate local messaging that people can relate to help enhance the kind of national messaging, and that is true for the vaccine. So whether it's translating things locally into various languages, or just giving the kind of Reading story or case studies, that's been our approach. And we've done a lot of work providing question and answer material, and trying to address some of the myth busting. And I know other colleagues have done that. There's been some really helpful information, for example, from Health Watch, which has gone through various question and answers just to help get the kind of right information out to people. So if we move on to the next slide, one of the things we know, although we don't have all of the data that we'd like yet, we know from experience that some of the ethnic minority groups in Reading have a lower uptake of other vaccines, and we already know from COVID that some of the impacts are actually greatest within that community. And some national survey work was done asking people about their intention to get vaccinated prior to the programme actually rolling out. And there was some greater amounts of vaccine hesitancy within some ethnic minority groups than within some white British groups. So instead of waiting just for the data to kind of come through that showed any differences in uptake, we've wanted to try and take a proactive approach in how we best engage with everyone in Reading, so that people have the opportunity to get the information and get vaccinated. And this all kind of revolves around trying to ensure that people have confidence in the vaccine itself, that it is convenient, and I've talked through some of the locations currently where the vaccine's available, and also tackling any complacency where people don't perceive that they would have a need to get vaccinated. So you can see some of how we we have engaged and sought to work with our ethnic minority groups on the slide here. And we've been certainly wanting to work with community leaders so that we're helping get a local and trusted voice out to people to kind of carry the message about vaccination. We've been wanting to have an engaging and an empowerment approach. So we have undertaken various kind of engagement in various ways. One of the things that we did 2 or 3 weeks ago was to have an evening kind of webinar Zoom call with a range of community and faith leaders to talk through some of the vaccine information, but to understand what some of the barriers are that their communities face and how we can together look to overcome those. So on the next slide, if you could move on, please, Claire. We've listed some of the key stakeholders that were either on that webinar or that we've been seeking to connect with more one-to-one. And again, I know that that Healthwatch have also run similar things, and I think earlier this week had events where the idea is it's not just a monologue, but you very much, you know, although there may be information to present, you listen and try and understand what the barriers are and how those can be overcome. So out of that, then we've got some key kind of ongoing actions out of the initial preparatory work, and then the that webinar that we run, and we're really looking to see how we best co-produce some materials. So talking with then specific community group leaders and understanding what type of material, be it a video, be it an information sheet, whatever else, that would be most useful and the content that can be within it, so that we together can kind of help address the gaps and the barriers that we're finding. And through the clinical commissioning group of the NHS locally, there is now a kind of an inequalities and uptake subcell, which is specifically looking at how we can ensure that work is joined up across the local area, and to ensure that we're making the vaccine as accessible as possible. So I think those are the main things to say regarding our the actions that we're undertaking. The final bit for me then on vaccination is just to kind of show some of the questions that that were asked a lot in those forums and in those dialogues. I've just kind of put on the slide here, and it's important that we're able to answer and address these, because they are the kind of things that people want to know and understand. And I'd be interested in the kind of comments and questions bit after I've finished, and then after Rachel from RVA has updated on what they're doing. If there are other key kind of questions or concerns or anxieties or barriers that others have heard of or are kind of frequently seeing. But we know that the vaccine is effective, and there's increasing numbers banded around in the media. Because there's been a range of vaccines, there's been a range of studies, and there's now real world kind of data coming through from Public Health England. But we know that the vaccines are highly effective, but sometimes those having not just one number put on its effectiveness, but a range of numbers, and depending exactly what outcome is measured, can end up confusing people. We know in terms of that second question that it works well against the variant that I described earlier on the previous agenda item, and that it remains effective even against the virus as it has mutated in that way. We are asked quite a lot about whether it's preferable for people to simply rely on the kind of natural infection that the immunity, they may have developed from natural infection, as opposed to vaccination. But the research has shown us that people generate a stronger and more sustained immune response when they've been vaccinated than simply when they have built up antibodies because they have caught COVID from somebody, and it's quite safe to offer vaccination even if someone has previously been infected. And one of the things we'll probably ask more than anything else is about the speed of development of the vaccines that we have available, and the fact that it feels like they've become available quite quickly, and what we've seen with the vaccine development is that none of the safety and quality measures required to get a vaccine approved have been sidestepped or short-circuited, but rather the funding for the research groups that would have been developing vaccine was all provided up front. So that there wouldn't be delays where they had to bid for further rounds of funding. And similarly, the data submissions that they are required to make have been done in an ongoing way. As data has become available, they've submitted it, as opposed to waiting until all of the trials are complete and then submitting it in one large chunk. So the process has been deliberately streamlined, where there were efficiencies that could be made within it, but none of the safety elements have been compromised. So that, I think, is all I wanted to say on vaccination. I'll hand over to Rachel Spencer from RVA, who will highlight on just how the voluntary sector has supported the rollout. And then, as I say, happy to take any comments or questions.
Hi, yes. Afternoon, everybody. I see actually that Dr. Sharma had his hand up. Should we take questions at the end, or is that okay?
Is that okay, Mr. Sharma, if we take the question at the end? And the
yeah. Okay, all right.
Okay.
Thank you.
And I'm actually going to turn my camera off because my connection's not brilliant, so I'll turn my camera off.
Of course, Rachel, you go ahead.
Thank you. Okay, so I'm just going to share a couple of ways in which the voluntary sector is supporting the vaccine programme, and that's really around coordinating volunteer support, but also we've got a partnership of groups who are working together.
Sorry, Rachel, can I just interrupt? At the moment, we've got, and this, oh, sorry, it's actually what I've done. I've got Mr. Sharma up very big on my screen. It's not everyone. It's, I think it was just me. I will butt out. Sorry about that.
No, that's okay. So have I, but that's fine. Okay, so yeah, so two ways really: providing volunteers and coordinating volunteers to support the vaccine hubs, but also we've got a partnership of groups and organisations that are working together to support those people at risk of missing out, of being able to access their vaccine when they're eligible. So in terms of supporting the hubs, we're working with the primary care networks, and it's really been as much as they've wanted and in ways of which they've wanted. So for some, that's providing 2 or 3 volunteers in a car park. At Watlington House, it's now involved more than 50 volunteers there, doing a range of roles: marshalling, admin, observation. But for the main role that they have, together with the GP practice teams who are doing an absolutely amazing job, is providing a warm welcome and a really positive experience for the local residents when they actually come along and have their vaccine. It's been a very positive experience for the volunteers themselves. We've had great feedback and they've really enjoyed being able to play their part and being involved. And increasingly now that Team Reading is diverse, as the various community groups have engaged and involved volunteers from within their membership, which has been very helpful in the hubs themselves, because obviously they bring diversity of language and cultural appreciation, but also they can then go back to their communities or their members, whatever it might be, and share that kind of positive vibe about the hub. And let people know they're going to get a warm welcome and overcome some of the challenges that people might have. So the second thing I wanted to talk about was the No One Left Behind group, which is a partnership of voluntary organisations who, as I say, are working with those people who are potentially at risk of not taking up their appointment when they're eligible. And some of the barriers that we've identified are around language or cultural factors, disabilities, whether that's learning or physical disabilities, mental health and anxiety, mobility, particularly when the older groups were first becoming eligible. For some of those older people had not left the house for almost a year and were coming out for the first time, and it was quite snowy. So certainly mobility was an issue. Actually, can we go back a slide, please, if that's okay? Thank you. And also circumstance. So with people who've had transient communities, they're not registered with a GP, could be refugees and asylum seekers. So we don't get into discussion around the vaccines. We absolutely leave that to David and his team, and also the NHS itself. Our purpose is really to sort of share that positive momentum around the vaccine programme and provide just practical support to help people access their vaccines. And in some of the ways that we do that, we've listed on the screen here. So that can be registering people with a GP, because if you're not registered with a GP, then you won't get invited for a vaccine appointment. Actually making the appointment itself can be quite challenging for some people, especially if they are not online, or as I say, there could be some language barriers. We're arranging transport for people who might not want to use public transport at the moment, understandably. They may not have family nearby, or they may need support from Redibus to do that kind of door-to-door support to the hubs and back again. And then just sharing information that is publicly available to just enable them to make an informed decision. And we've also got kind of specialist buddy support, whether that's people who are befriending as a result of ASD or a language support or whatever it might be, to encourage them to actually get to the hubs and to get their vaccine. We've set up a central helpline for the voluntary sector, and that has language line support as well, and that's now available for all the volunteers as well across the town, so they can access through the RVA, back phone that they have, and language line, which is fantastic and something we should have done years ago, to be honest. So that's one of the learnings from us, been really good. So the other information, so if we move back to the next slide, if that's okay, thank you. I just thought it might be useful to show, we did a sample, it's actually 52 people, contact 52 people who were eligible for their vaccine, but had not yet taken up their appointment. And of those people, it's just a snapshot. Obviously, it doesn't give the sort of comprehensive data that I know we're waiting for. But of those people, 19 people did actually have an appointment booked. So that was encouraging. 3 people couldn't yet have the vaccine because they were having other treatment, but were under some supervision. 8 of those people were supported. So they wanted to get their vaccine and they needed help to make the arrangements and to get there, or needed a little bit of confidence. And 3 of them were unsure and hadn't decided yet whether they were going to have the vaccine. So that's a sort of positive nudging in the right direction. And 19 we were unable to make contact. So quite positive, given the high levels of take up anyway. So for those people who've not yet taken up, even there, sort of great momentum and support to enable them to access their appointment as and when. So some examples of, just a couple of really quick examples of what the group has done. So we've got the, one of the members of the group is called BIG, and it's an Islamic gardening group. They've done a fabulous job of supporting their community throughout the year. And they've arranged for messages to go out through the Friday prayer announcements through the mosques. So they've shared information and sources of help, but they've also recruited volunteers. So several volunteers have been recruited in that way, and they're now joining Team Reading and a part of the hub, and just generating that kind of positive feeling about being able to get the vaccine and what difference it can make for people's lives in the future. And another example is Reading MenCap, you probably know, who supports people of all ages and their carers with learning disability, in the town, and they've contacted 120 people to prepare them with the arrangements for them to access their vaccine, making sure they're registered, that contact details are all up to date. They've got a minibus, so they're arranging transport as and when needed, which has been really positively received. And a couple of notes from them is how much they've appreciated it when carers and individuals have been vaccinated at the same time. And we understand that's discretionary depending on the situation at the hub on that day, but hugely valuable for those families who would otherwise have to arrange respite for that carer to access their vaccine. So that's one thing to note. And the other thing is that quite a few of the unpaid carers that are registered with them are not actually registered yet as a carer with their GP. So they're kind of working on that and highlighting that. So I just wanted to share that as a little bit of an insight in the role being played by the voluntary sector. Thank you.
Great, thank you for that, Rachel. I thought the final bit about the support in the rollout, I thought was really interesting, particularly in the sample of 50 and how that went. Okay, got Dr. Prem Sharma is indicating.
Yeah, first I want to comment David's presentation, very comprehensive, and the other presenter also. I commend you for that one. All this time we have been talking about the vaccination, and it is the first dose, or there is a plan also for the second dose, and when it is going to start. Any date for that one? David?
Mr. Monday?
Great, thank you.
Mr. Andy Chichersky is also indicating, I don't know, is he's very closely connected with the vaccine rollout on the ground. I wasn't quite sure if you're indicating to respond to this, Andy, David, or to speak later.
David, you go first, and I'll add if needed.
Fine. Okay. Yeah. Okay. Perfect. So, the data that I showed in terms of the number of people in Reading that have been vaccinated is almost entirely dose 1 only, not dose 1 and 2. And the plan with dose 2 is to give that second dose in the kind of window of time between 10 and 12 weeks, and Andy may give the absolute kind of window, the absolute time frame, but between 10 and 12 weeks after dose 1, to give that kind of second injection at that point. What we know from the data is that we're seeing something like 75–80% effectiveness with dose 1, and then we think that the dose 2 adds on an additional 5–10% in on top of that. So the strategy has been to get as many people dose 1 as possible, because that's by far and away the most important thing to do, and then to follow up at that 10 to 12 week point for the second dose, to ensure that the immunity and that response is boosted, and you get the longevity of the immune response against the virus. So we started vaccinating people in December. So simply for individuals who have had dose 1, it's that 10 to 12 week point later that we would give the second dose. Andy.
And excuse me, when you talk about second dose, the GP surgeries will contact you, or?
Yeah, yes, absolutely. So in some setups, so for staff that have gone to the hub at Wokingham Community Hospital, they've often been given that appointment before they've left, because of the way their systems worked and the way that the supply going into those hubs has worked. But yes, in primary care, people don't need to kind of chase. They'll be contacted about that dose 2. But I'm sure Andy will make further comment as one who's kind of doing it day in, day out.
Right. Thank you. Thank you very much.
Chersky.
Yeah, just to confirm, yeah, so the second dose ideally will be in the 11th week, but they've said there will be ±7 days. So as David says, in that window between 10 and 12 weeks, I think we're just going to wait for confirmation of our vaccine supplies coming in the next few weeks. Some practices, some of the vaccination sites that started in December will be giving that second dose from next week, because that will be their 11th week. My site will be doing that in the last week of March, because we started in the second week of January. So yes, all the GP surgeries will be going through their lists of who they had vaccinated 11 weeks ago, and they'll be inviting patients to the clinics. We only get about a week's notice of actual vaccine supply, so we have to start booking the clinics as soon as we know the vaccine's coming. When we can actually put the clinics on, we then start booking the patients. So hopefully about a week in advance of the actual appointment for the vaccination, that's when we'll be contacting patients to book them in. That's the same process across all the vaccination sites and across all the GP practices.
Thank you.
Thank you for that. That's it's always good to hear, Dr. Chesky, the sort of the frontline experience of what's going on. Any other questions or points anybody wants to raise?
Can I come in, Cheryl? One
Yes,
of the questions that from David's quiz. There was one there about, can you have a COVID vaccination if you've had COVID? It's one of the questions we ask patients when they come for the vaccination is, have they actually had COVID itself in the last 28 days? And we ask patients not to have, well, we don't give the patient a vaccine if they've had COVID within 28 days. They have to be past that 4-week period to have had enough time to have recovered from the COVID to then safely have the vaccine itself. I was a bit unlucky myself because I had the vaccine before Christmas, and then a week later I got COVID. So I was must have caught COVID just where the vaccine wasn't quite working yet strongly enough to prevent me getting it. But I'm now super immune. So I've got both natural and vaccine immunity on board. So I don't wish it on anybody though. Just get your vaccine and get protected.
Thank you. Yeah, no, thanks for that. Can't see anybody else indicating. I would just like to say, I think it's really handy and useful presentation in terms of the vaccine rollout. It has been a huge frustration, I think, in terms of the lack of data that's in public in terms of how the different primary care networks are and areas are doing in terms of the proportions of people receiving the vaccine. And one of the things that is happening is that within that vacuum of information, there's lots of rumours flying around that people up in Caversham Heights are all getting it and none of us down somewhere else are. And I think it would be great if we can move on to, I know this is not within any of our sort of responsibility or ability to change, but it'd be great if those some of that information became more public, because actually what I've been able to see confidentially and unfortunately not been able to share because the NHS won't allow us, shows that the various different primary care networks doing a fantastic job, and where one falls behind they start to catch up, and it's being done on a really good basis. And I think the other thing that we absolutely do need is also that data around Tevye Markson, I was about to say, he's our local government reporter, said that the data is available by zones. Now we're in Reading. Unfortunately, that's just led to further confusion because, of course, the zones are not of the same geographical or even demographic makeup. So the fact that it looks like more people have been vaccinated in one area than another means nothing until we know what proportion of the people in that area have been vaccinated. So that's, even then, is leading on to further concerns that people are not being treated fairly. So I think that's something that is really important that we could move on with, but unfortunately we've got that confusion at the moment. And finally, I think what is also going to be really critical for us is going to be that data around geographical and social groups where take-up isn't as great as it should be. Some of that could be where people naturally just perhaps a little living further away from where vaccination hubs have been, and or where a reticence about getting the vaccine. I think that's the kind of information that we're really going to need in order to focus on increasing the vaccine take-up where it's at its lowest. So it's not really expecting a response from you, David, because I sort of think I moan to you all the time about, but certainly it's something that we need to be looking that we can action on in order to make sure that we don't have particularly the danger of social groups, maybe that be ethnic minority groups who are less vaccinated, which would just create a further level of health inequalities in our town that we really want to seek to avoid. So I've got Dr. Andy Chersky. Were you indicating again, or was that from previously? I think you were indicating again, Andy.
I'm indicating again, yes, just to express there has been a lot of frustration, especially in our vaccination sites, because I think we felt we could have done more. I think it was mentioned, Rachel said there was a huge impetus and enthusiasm for vaccination, and certainly amongst primary care staff, there was a huge amount of all hands to the pump was how I described it back in January when we started. And I suppose there's a little bit of frustration that the vaccine supply hasn't really kept up with that momentum and getting through all the patients. But there is the element to understand as well that there's over 1,000 vaccination sites across the country. And now we've got the mass vaccination sites coming on board as well. And it's a huge logistical issue. I'm sure David must understand this as well, of trying to get vaccine out to the sites. I suppose I've tempered my frustration a bit over the last few weeks because I understand the logistical difficulties and the fact that some vaccination sites did not get enough vaccine, and we've actually had to help each other out to make sure that we got through the highest cohorts, the 1 to 4 cohorts, the highest at risk, to make sure they got vaccinated first. And until that group got done, really we couldn't really push on with the next cohort. And we're into cohort 6 now because we are the GPs know who the patients with clinical conditions are that need to be vaccinated as the next priority, because actually age-wise it's much easier just to call patients up, whilst actually targeting patients with specific clinical conditions is more difficult. But yeah, I think we're all just enthusiastic to try and keep going, and now get that enthusiasm going again for the second vaccinations to make sure that patients get that second vaccine, which will boost their immunity even further. And that's going to be a big logistical issue, and hopefully the vaccine will flow correctly so that we can do that. Thank you very much.
Great, thank you for that. I think that's really useful. And to be very clear, it's more the powers that be higher up within NHS who unfortunately are not necessarily releasing some of the information I think would be really helpful to have locally, so some of those rumours are not swirling around. The sterling efforts locally by the NHS have been magnificent, and I would say it shows what happens when you allow public sector and the NHS to get on with these kind of jobs rather than outsourcing to private companies. But perhaps I ought not say that. Right. Okay. So unless anyone's got any other questions or any other points they want to raise on that matter, clearly there's going to be lots of further challenges and lots of issues as the vaccination process across the town, and lots more to be done. But thank you for the presentations and the work that everyone's doing on that. Okay, then, so the last main agenda item is the local outbreak control plan. This is you again, isn't it, Mr. Monday?
It is. Thank you, Chair. A couple of colleagues that have been working more closely on the lateral flow device programme in Reading aren't available today. So I said I would happily kind of speak to this. So apologies, you've got my voice again. But the reason that this is on as an agenda item, so at each of our outbreak engagement boards, we talk about developments and changes to our planning around how to control the virus locally, and probably apart from vaccination, which we've obviously covered now in a reasonable amount of detail. One of the things that then has changed most since this outbreak engagement board last met is about testing locally, and I wanted to therefore update particularly about lateral flow device testing. So if we move on to the next slide, please, Claire. Before we go into the detail of that, just to give you the oversight of testing in Reading first. So our testing rate in Reading is actually very good. It was on one of the previous data slides, although I didn't draw it out specifically. And the reason that we monitor that is because it's important that we know that people in the town are able to access testing and do access it, because clearly we need to be able to identify where people have become infected with the virus. We do then keep quite close monitoring to look at where looking at different groups within the borough and where there may be any differences in engagement with testing, so that we can try and ensure that it becomes more easily accessible if there's any barriers to it. And we do get a pretty good turnaround time here in terms of the time between having a test and getting the result. And so since this board last met, we have now converted Prospect Park to what we call a local testing site. So that's available to people 7 days a week and offers testing using what we call the PCR swab test, which is the main lab-based test that is used for detecting the virus for those who have symptoms. And we've also been working up plans in terms of how we would deploy what's called surge testing locally, if that was required. And I spoke earlier about the variants or the mutations of the virus, and they sometimes get referred to as variants of concern. And people may have seen in the media over the last 3 or 4 weeks, there's been various parts of the country where they've done surge testing because of the South African variant, which is not at all highly prevalent in this country. And the idea of surge testing is that if cases of that are identified, you then deploy kind of mass testing in a particular area to try and identify every last case of it, so that it can be isolated off and it doesn't start to spread. So we're developing our plans, and so that if we're required to do that in Reading, we would be ready and able to do so. And then we've got the lateral flow tests, which are increasingly becoming more available. And I will just talk through then what's happening kind of with that. So on the next slide, please. So the lateral flow test is like the kind of gold standard or the main PCR lab test that we do, is still looking for the viral antigen. So we're looking for the virus itself with the lateral flow test, and it works in a similar way to a pregnancy test in terms of the actual technology. You don't then need to send the kit to a lab to be processed. There's a panel that an individual can just read the result themselves, and that comes through within 30 minutes of having undertaken the test. So it's quick, it's rapid, it's convenient, and is obviously a useful kind of technology, a useful development to have available. We're primarily using it for people that don't have symptoms to detect if they've picked up the virus and aren't aware that they have, and that means we're using it in the groups of people that are being offered this testing. We're recommending it's used in an ongoing, regular way, as opposed to just simply a one-off. And we know, I think most people have heard the statistic, which is quoted quite a lot, that around a third of cases of COVID-19 don't present with any symptoms, and therefore people wouldn't know that they might need to go and get the traditional PCR swab test. So that's where this type comes into its own. It is that convenience and speed that I referred to is kind of countered by the fact it's less accurate, and I don't think anyone would pretend otherwise, that it's less accurate than a PCR test. So what that means is that we can use it, and I've used the phrase case finding there, to try and identify additional cases where people wouldn't have had symptoms and they may not know they're infected. But it's really important that when people get a negative result, and the majority of the time when people use one of these kits they do get a negative result, that doesn't mean that they then discard the other control measures that they should be following to prevent transmission of the virus from person to person in Reading. So they need to maintain the requirement for social distancing. They need to continue to wear face coverings where they're required. The limits on social interactions remain, etc., etc. So and that's because we know that there are instances where the test shows that someone is negative, they're not infected, but actually there is virus that's present. It just hasn't accurately picked that up. But that notwithstanding, using it in this case finding way where you regularly use it so that you find more cases and that those people can isolate, not having otherwise known that they had COVID, and can avoid inadvertently transmitting it to others is really valuable. So in terms of where this is happening in Reading, so the University of Reading was probably the first place that kind of systematically had this available. They tested students prior to going home for Christmas. They've tested students that have been allowed to return since the Christmas holidays, and they now test anyone who's on campus for those practical face-to-face courses, and their staff that are working on campus twice a week, every week, to check for any infection that otherwise wouldn't have been detected. As we've already heard, this started to be available in schools for students that were in secondary schools and returning as part of the vulnerable group or the key worker group, but it will now be available to all pupils in secondary schools. It's already been available to staff working in secondary schools, and recently became also available to our primary school staff, and is now being made available to nursery school nursery staff generally as well. The kits have also been used, then are continually being used within the health and social care workforce. So whether people are working in a hospital, whether people are working in primary care, whether people are working in care homes, in domiciliary care, etc., then regular testing is available again to ensure that people haven't picked up the virus and could transmit it to those that they're caring for. And we've now got capacity to support in outbreaks, and we talked a bit about the outbreak from James Crosby's update earlier. And in those kind of scenarios where it's useful to do mass testing to understand how far the virus has spread in a particular outbreak, we've now got some of that structure in place to be able to do that. And then the latest innovation is then testing what we've called key workers, but really simply those who at this stage, despite still being in lockdown, aren't able to do their job from home, whether that's paid employment, whether that's voluntary work, and need to be out and about for their job. And we're now able to offer them testing too, and again on that twice weekly, every week basis to check that they haven't inadvertently picked up the virus. So on the next slide, there's just a little bit of detail of then how we're doing that rollout to the key worker cohort, if you like, within Reading. So we've got 2 sites in Reading, although staff workers in Reading can attend any site in Berkshire or indeed, in Oxfordshire, Hampshire, depending where they live and where's most convenient for them. And I've got on a subsequent slide, I'll show you the links and how people kind of book in. But in Reading, we've got then the South Reading Leisure Centre opened for this as a testing site for this programme 2.5 weeks ago, and then 2 weeks ago, Rivermead Leisure Centre also opened for this testing. And on the booking link, which I'll show, you've got we lay out who those 14 essential worker groups are, i.e. those people that can't work from home that can access testing via this route. So we've been doing a reasonable amount of communication and promotion of this because we're really keen that people engage with this testing offer as one of the ways that we can reduce the spread of the virus locally. And on the next slide, if you can move on, please, Claire, we've got the just some examples of the flyers that we've made available for, on the left, the South Reading Leisure Centre. If you can read, the font's fairly small, and then also the Rivermead site as well. And we've been sending letters out and emails out to employers who are working in the sector of groups who are eligible. We've been making direct contact via the links to the council. So, for example, our team that link with nursery staff have been liaising directly with the sector about ensuring that they're able to have access. There's information on our website, as well as using some of our other local media channels. So if we move on to the next slide, in terms of what's happened to date, So we took learning from some other areas that implemented this testing earlier than we did, to understand what happens about demand for this. And really what their experience showed was that you get an emerging and building kind of a bit of momentum, a bit of that snowball effect in terms of demand on these test sites. So we've started small and are expecting things to grow. So currently we're receiving bookings at about 50% of our capacity. So we're doing more of the promotional work to get more people through to get tested who are eligible, and then we can expand our capacity as there is demand for that to be done. We're obviously wanting to just ensure that we're ramping up then that engagement and communication work to get the message out. We know that nothing in this pandemic response remains static for more than a few days, a week or two. So some of the groups that we had anticipated inviting into our test centres are now being offered home testing service directly by NHS Test and Trace. So our nursery staff are a good example of that in Reading, where we were looking at how we could accommodate them coming to our test centres, but actually all nurseries in Reading will now be sent test kits directly to the nursery for then staff to be able to just test at home, and then there's that more convenient with the shift work and the hours of operation, etc. for testing being done that way. So we continue to tweak the model as things evolve in terms of the national programme. So up until the 19th of February, we had tested 773 people and had found 2 cases of people who had no symptoms but were positive on those kits, who we could then isolate, do the contact tracing and ensure that there was no further spread of the virus. But those numbers were going up again on a day-to-day basis. And then the final slide then for me on this is just to show you where those booking links are. So, and these slides will be made available, as we said at the beginning of the meeting. So there's a hyperlink through for each of the local authorities in Berkshire. So for people who work in Reading but live elsewhere, for people who live in Reading but work elsewhere, etc., it's just a simple go wherever is convenient for you on your way to work, on your way home from work, during your lunch break whilst you're at work, etc. The geography doesn't need to be a barrier. And for those who are outside of Berkshire itself, then the link right at the bottom is actually to the NHS website, where all testing sites, both these lateral flow sites, but also the sites for PCR testing, are all mapped out. So people can see easily where they can go to get this type of asymptomatic kind of regular testing, get that done in, as I say, in the place that's most convenient for them. So that's a bit of a rattle through, but I hope it is helpful, Chair, and happy to take any questions or comments on this lateral flow testing programme.
Thank you, David, for that pretty comprehensive overview. Any questions? Anything? I've got Andy Shchesky. Andy.
Yeah, David, you mentioned nursery staff. I'm just wondering what other key workers, are there sort of big numbers of particular groups that are using the service versus others, or is there quite a widespread?
Yeah, thank you. So we've got, so you're absolutely right. The nursery staff are there. We're also within that wanting to include childminders. So at this point, they may get set up to be able to do home testing at some point, but at this point, right now they can come to our testing centre. We've got those who provide care but are not CQC registered, so personal assistants who provide care, or unpaid carers can come and be tested. Transport workers can come and be tested. So things like Redibus, school transport, taxis, etc. Then anyone within the voluntary sector that needs to be out and about for their role can come. Funeral directors, undertakers, coroners, vets. It's a reasonably long list. So some of those groups are larger, some of those groups are smaller. But overall, it's actually a fairly sizable number of people in Reading that are eligible based on the fact that they need to be out and about for their role and can't simply, in a way maybe that I do, or many of us are becoming accustomed to work kind of remotely.
Thank you, David. And David, you'd be glad to know that Councillor Jane Stanford-Beale says she went today and it was very quick and well organised. So I'm not sure. If she's something else, a bit more negative, I might not have read it out quite.
Good to get that feedback.
Good. Right, I've got Mandeep from Health Watch and then Dr. Sharma as well, as just indicated. Thanks. So, Mandeep.
Thank you, and thanks, David, for that presentation. I do have a question, but it's not about lateral flow test. It's about the COVID engagement outbreak plan. Oh, sorry, the COVID outbreak control plan. And we've heard lots today about how things are progressing. I just wondered if you had an update on how care homes are currently coping in Reading.
Yeah, I haven't got specific kind of data on the on COVID cases within care homes, but what we have not seen to any kind of extent the same measure that we saw in the first wave is that same kind of impact on care homes, and that I think is testament to the hard work of the staff working in the sector, the fact that PPE has been available, kind of from the off in more readily available forms, and all the infection control kind of processes are there and in place. So certainly the impacts have been much less dramatic and challenging than they were in the first wave. And where we have seen death from COVID in Reading, it's not been within care homes, but far more where people have become acutely unwell and had been admitted into hospital, because we get that breakdown from the Office for National Statistics each week. So offhand, that's probably the best answer I can give in terms of the care home impact. And clearly, a lot of work's been done to promote the vaccine uptake. Within our care home residents themselves, that's been kind of virtually 100%. And with staff working in care homes, we continue to engage and support them to get vaccinated too.
Okay, thank you. Dr. Sharma.
I've got two questions. One is that this testing process will continue even those people who have been vaccinated, they will also be tested. And second question, those who have been vaccinated, first and second dose, will they be provided a kind of passport or anything so it is a record that they had 2 vaccinations and they are okay?
Thank you. Yeah, two really important points, and I should have mentioned about the first within the kind of eligibility element of the presentation. So really glad that you raised that. We are asking people who are vaccinated to have the lateral flow testing in the regular way that I described, and there is overlap clearly, because when you take, for example, we were just talking about care home staff, to use them for example, clearly they're people we want to be vaccinated against the virus, but also those that we want to be testing with the lateral flow test. So yes, absolutely. If people have been vaccinated, we still want them to be engaging with this regular testing. And the reason for that is that it takes around 21 days, maybe a bit longer, for your body to build up immunity from the first dose, and you need the second dose to get that fuller immunity. But even then, no vaccine is going to be 100% effective. They're very effective, and we can already see that in terms of our rates in Reading, but they won't be 100% effective. So it's not, the vaccine does not then mean that people can't possibly pick up the infection. So them having the regular twice weekly lateral flow test remains important.
Excuse me, is there any time interval after somebody had the second vaccination and the time you gave for the testing? I mean,
so you don't need to interrupt the testing kind of regime because of vaccination. You do, and we've already talked about, Dr. Dzerzhinsky talked about the interaction between becoming, if you test positive for COVID, and that kind of delaying vaccination, you need to have that 28-day window. But in terms of doing regular testing and vaccination, they can run kind of alongside each other, and you don't need to avoid testing immediately around the time of vaccination. On the second question about the passport certification of for people who have had vaccination, at this point the message coming out centrally from the government is that that's something that's being explored, and we will take in Reading, we will kind of take the lead from what is agreed and announced kind of nationally on that. At this point in time, whilst we're still working on vaccinating the population of Reading, I think the important message is that people continue to follow the lockdown advice and then the changed guidance as we move through the roadmap, as it's been called, and have that release, even if they've been vaccinated. We don't want people to see it as the green light to kind of not follow those rules, because we need to ensure we've got good coverage of the whole population, and also we know that despite vaccination, some people can still get infected. The passport certification bit might come, but we'll wait for the national kind of policy on that first.
And the last question, David, this testing, the testing will continue. How long it will continue? All the time, or there is any duration, 1 year, 2 year, or?
Yeah, important question. I think we know at the moment it will continue well into the kind of roadmap timescale of the kind of release from lockdown, but we don't have a specific framework or timescale around when it might be able to be stood down. So I would anticipate it will run kind of well into the summer and probably beyond. But I think that's one of the things as we move through the kind of release from lockdown, as we move through this acute phase of the pandemic, will become clearer kind of in time.
Thank you.
Thank you. I've got Dr. Cheshky.
Yeah, maybe just to support you, maybe not so much a passport, but every patient that has a vaccine gets a little credit card sized card with the name of the vaccine they've had and the date they had it. And it's got 2 lines on it for first vaccine and second vaccine. I'm sure there'll be many who will forget to bring it when they come for their second vaccine, but then they'll have 2 cards. So at least you get a little gift from us when you leave. You get an information leaflet about which vaccine you've had and all the side effects to look out for. But you do get a little credit card size you can put in your wallet to remind you of that you've had it. I'm not sure it's going to act in any official way according to the, as a passport, but at least it acts as a proof that you've had it, and also a reminder of when you had it, and if you had the first one, a reminder that you still need a second one.
Thank you for that. And yeah, I think there's, to be fair to the government, I think there's some quite difficult decisions, ethical decisions to be made around how a vaccine passport would work, and certainly kind of in their court, so to speak. Thank you. Is there any other points, questions anyone wants to raise? I haven't seen anyone else indicating, in which case, thank you, David, for that. That was really, really useful information. Then in which case, the last item is actually the date of the next meeting, which is on Friday, the 23rd of April. Between that, we do have a Health and Wellbeing Board, which is mid-March, and there will be within that an agenda item around an update on the COVID situation and a couple of things from that. So it will be covered. So thank you, everybody, for the excellent presentations. I think a couple of people have mentioned some really fantastic work, hard work that's being done across the town and the wider area in terms of dealing with this pandemic. It's really heartening to see, and I hope everyone has a lovely weekend, unless of course you happen to be working over the weekend, fighting this pandemic. So thank you, everybody.
Chair, did you want
Thank you.
Chair?
Oh, sorry.
Tony Cowling had arrived. I didn't know if they wanted to say anything to him. He just
Sorry, yeah,
arrived recently.
Yeah, so obviously we answered your questions in paper format. You've obviously got the answers to those. This meeting is recorded, so you can have a look at what we've been discussing, and if you want to come back to me in terms of anything from those questions, and obviously please, you've got my email, please don't hesitate to do so. Okay, thank you, everybody. And as I say, have a good weekend.
Thank you very much. Very nice.
Thank you.
Thank you, Chair.
Thank
Thank
you,
you.
Councillor
Have a good
Crosby.
weekend.
Chair.
Bye.
Thank you, everyone.
Bye-bye.